Future Pulse, Patients First, investigating innovative cardiovascular research with a patient-oriented clinical outcome focus. I'm Dr. Thomas Nero, clinical and interventional cardiologist and director of cardiovascular research at CAFC. Good morning and welcome to Patient Pulse. I'm Dr. Tom Nero. Today I have the pleasure of speaking with Dr. Stefan Neubauer. We're going to be speaking about coronary inflammation and cardiovascular risk assessment. Coronary inflammation is probably one of the most important and yet poorly understood aspects of cardiovascular disease. Dr. Neubauer recently published a couple of papers which are quite interesting regarding coronary inflammation, which we'll be discussing today. If you're interested in the topic, there's also a deeper dive into this on Future Pulse Cardiology, which you can also find at most podcast services. Enjoy. What we wanted to talk about today was coronary inflammation and how it occurs in patients with coronary artery disease and why patients should be somewhat concerned about this.
We were lucky to be able to access the largest database of cardiac CT scans that are paired with information on clinical outcomes. I should also mention that coronary CT is now really the only reliable non-invasive method to tell us exactly what's going on in the coronary arteries. So what sort of diseases, heart diseases, will patients suffer in the years following a coronary CT scan? So what this study showed, first of all, is that those patients who have a coronary CT scan, because they have the typical chest pain, the typical angina, about 80% of those patients who have this scan don't actually have significant narrowings. 20% do, and then they go on and have things like stents put in and bypass surgery, etc. And of course, those patients who have the narrowings, they are more likely to then have clinical events like heart attacks, etc. But because that other group that currently is usually reassured is so much larger, it's 80% of that cohort, in absolute terms, there are actually more of these clinical events happening in that group that is currently usually reassured by conventional CT scans. So the first thing that this study suggested is that there really is a need to improve the management and the advice we give to this group of patients who are currently typically reassured with a coronary CT scan. So then the second thing is that we in Oxford academically and also with our spin-out company, Caristo, we developed a new technology that, broadly speaking, is based on looking at the fat around the coronary arteries and quantifying whether this fat is inflamed or not. And we know that this inflammation in the fat tissue around the coronary arteries is really a main driver for coronary atherosclerosis, so for the furring up of the arteries. And what we found was that this measure of inflammation in about 3,400 patients is a very, very strong predictor of who gets this clinical event or who dies from a heart attack, etc. And this works actually in patients who have significant narrowings on their CT scans, but it also works in patients who don't have significant narrowings. And even in patients who don't even show the slightest signs of any what we call plaque building up in the coronary arteries. And then the third thing we found was that when we compare the way that doctors currently assess their patients for their level of risk and decide whether they should have treatments like statins or maybe even more aggressive things, that then this new test actually what we call reclassifies many of these patients, about 40% or so of these patients, either to a higher risk category or to a lower risk category. And then finally, when we gave this information to the treating heart doctors, they actually changed the management of these patients in about 45% of this cohort. So this new technology can help us to fine-tune the way we manage risk in these patients with coronary heart disease.
It's quite exciting technology. Unfortunately, it is not yet available in the United States. We are doing more CTAs in the United States now, and we're far behind our European colleagues in doing CTAs. I think one of the take-home messages that I got from your trial was that a narrowing is not necessarily the way to determine whether someone has heart disease, that it really has to do with plaque, and more than plaque, it has to do with the metabolic activity in that plaque and coronary inflammation. The main way that we're looking at it currently is by the use of hsCRP, and a lot of people who are listening will probably know hsCRP or have it performed. But that hsCRP is a very non-specific, very sensitive, but very non-specific marker of inflammation, where the scoring that you're talking about is highly specific and highly predictive.
Yeah, you're completely right. And I think the only thing to add to this is that, as you hinted, this technology is currently already available and regulatory cleared in the UK, in Europe, and in Australia. So it's CE marked, and etc. In the US, we are very much working on FDA clearance, and we hope to get this within the next 6 to 12 months, so that this method can also be used clinically in the US.
As a research modality, it is very, very interesting to me as a researcher. But ultimately, as a clinician, I would love to be able to have this available to my patients. And it is something that I've talked to a number of my patients about, that it may be coming. And I'm keeping my fingers crossed that it's come sooner than later, because it is going to be something that I think in the future we're going to be using a lot of. One of the other papers that you recently wrote was demonstrating the efficacy of a therapy based upon improvement in PHI score. And if you could go upon that just a little bit for a general audience, and then what you think that this means for the future of how we're going to be looking at our pharmacologic regimens.
We also published a paper that we did with a pharma company from California called Abcentra, where we looked at one of their new drugs that specifically reduces inflammation in the coronary arteries. What this trial showed was that we treated some of these patients with this drug and other patients with placebo. And then following the treatment period, what we showed was that when you looked at the whole cohort, then this treatment only showed trends for improvement in inflammation. But when we selected patients for those who have high levels of inflammation at baseline, then this drug very significantly reduced the level of inflammation, and it also reduced the risk of dying from a heart attack later, according to our models that we use for this. On the other hand, if you looked at the patients who didn't have high inflammation at baseline, then the drug had no effect. So what this suggests is that this is technology that can help us select the patients who really need these new and often expensive drugs, so we can get them to the patients who really need them, and also make, obviously, the healthcare system more efficient and cost effective.
Clearly, this is an interesting trial. It's a very small trial. So this is one of those situations where we say, well, let's see what happens, because the future is always hard to predict. But that being said, it is extremely, extremely interesting. The drug was an antibody against oxidized LDL. And although it decreased that and decreased inflammation, it didn't affect LDL cholesterol, HDL cholesterol, triglycerides. It had no effect on those things. Yet it seemed to improve the coronary inflammation. So hopefully that will be an indication that it could improve outcomes.
Yes.
And I guess you're going to be going forward with the larger trials in this medication.
Exactly.
What I do believe that is going to be very interesting about this technology is that its ability to demonstrate effectiveness of therapy, which is something that we have not yet been able to do with other testing. Currently, our best way of demonstrating if something's effective or not is either decreasing LDL cholesterol or waiting to see if they have cardiac events. And I really don't want to wait till all my patients are 90 years old before I tell them that their therapy was successful. It will be interesting to watch how we're going to be utilizing this technology, both in the clinical setting and also in the research setting, because I think it will be able to create a faster pathway for drug development. I'm very excited, and I can't thank you for talking to us today, and also for all your work on this technology, because it's really fascinating and exciting.
Absolutely. You're very welcome.
Well, thank you again for spending your time, and I look forward to talking with you again soon.
Thank you.